Good afternoon, everyone. I'm Dr. Mansi and I'll be presenting before you a study of visual outcome in posterior chamber phakic intraocular lens implantation in high myopia. So uncorrected refractive errors are the most common cause of visual impairment and the second most common cause of treatable blindness in the world after cataract. Among these, myopia is the commonest refractive error, affecting about 27.7% of the total world population. There are numerous treatment modalities for the correction of myopia, among which optical correction using spectacles and contact lenses is the most commonly used approach, but it is often unacceptable in high myopics. In these patients, keratorefractive surgery or phakic intraocular lens implantation can offer a permanent solution. So what is a phakic IOL? It is a supplementary lens inserted into the anterior or posterior chamber of the eye to correct refractive errors. In these cases, accommodation is preserved as the eye's crystalline lens is totally intact. It is a boon in achieving spectacle independence in patients unsuitable for keratorefractive surgeries. So IPCL or implantable phakic contact lens. This is a single piece posterior chamber phakic IOL manufactured by Care Group Sight Solutions India, made up of hydrophilic hybrid acrylic material, which provides lenses correcting -1 to -30 diopters of myopia and +1 to +15 diopters of hypermetropia. This lens has 6 haptic pads which ensure a better stability in the ciliary sulcus. There is a leading left hole to ensure proper direction during insertion of the lens into the eye. There are 2 models, among which the V2 model has a central hole of 380 micrometers, which ensures proper aqueous flow. So the aim and objectives of my study were to study the visual outcome, the intraoperative and the postoperative complications in patients with myopia of more than 8 diopters and myopic astigmatism less than 1 diopter after posterior chamber phakic IPCL implantation. So we conducted a hospital-based prospective interventional study at a tertiary care teaching hospital over 10 eyes of 5 patients. The patients included in my study were those with myopia of more than 8 diopters with myopic astigmatism less than 1 diopters in the age group of 21 to 35 years of age, having a stable refraction in the past 1 year with an anterior chamber depth more than 3 millimeters and a white to white or limbus to limbus diameter of more than 11 mm. And most importantly, these patients were unsuitable for keratorefractive procedures like those with thin corneas or metropia more than 13 diopters and severe dry eye. The patients excluded from my study were those with pre-existing ocular disorders, one-eyed patients, those with pathological myopia and endothelial cell density less than 2000 cells per millimeter square. So pre-operative investigations done in these patients included uncorrected and best corrected visual acuity, a detailed slit lamp evaluation, detailed fundus evaluation, measurement of the intraocular pressure, horizontal white to white measurement, measurement of the anterior chamber depth from the corneal endothelium to the anterior lens capsule, keratometry and endothelial cell count. Under pharmacological mydriasis and topical anesthesia and under all aseptic precautions, wire speculum was applied. 2 side ports were made at 12 and 6 o'clock. Viscoelastic substance was injected. The main port was made by a 2.8 mm keratome, clear corneal incision. The phakic intraocular lens was inserted through this main port. The haptics were tucked behind the iris with IOL tucker. Pupil was constricted with pilocarpine. A small iridectomy intraoperatively was done through the main port. AC wash was given, AC was formed, and subconjunctival antibiotic plus steroid was injected. So our study included 10 eyes of 5 patients, among which 3 patients were females and 2 patients were males. The post-operative best corrected visual acuity in my patients, in 5 patients, is ranged between 6/18 to 6/12, and in 5 eyes it was 6/9 to 6/6. In my study, no intraoperative complications were noted. The post-operative complications that were noted were 2. There was a cataract, development of cataract at the end of 6 months, which was visually very insignificant, and transient intraocular pressure rise was noted in 2 eyes. This IOP rise was due to steroid response, and as soon as we withheld the steroid and started the patient on anti-glaucoma medications, the IOP was returned to normal.
Please conclude.
So phakic intraocular lens implantation is now a commonly used and effective treatment modality for the correction of myopia. It is most commonly used for those who are unsuitable for keratorefractive surgeries. It also offers numerous advantages over keratorefractive surgeries like better contrast sensitivity, lesser aberrations and retinal image magnification. And this technique is reversible. So I conclude that the IPCL is a safe and effective treatment for the treatment modality for patients in high myopia. Thank you.
Few things. In your paper, you said that you all took the white to white from
laser
your biometry
and
the digital caliper.
Digital calipers, yeah.
So which one did you use?
Ma'am, digital one.
Use
The,
the
हाँ,
digital.
3 readings were done for each eye and the digital one was preferred.
Okay, not
Yeah.
like an average.
No, ma'am.
Okay. Also, if you're writing endothelial cell density,
Yeah.
right? You cannot say there is zero loss.
Yes, ma'am.
Yes?
Yeah.
Okay, there will be.
It
It
was-
has to be either a significant or a
It was not
non-significant.
significant. Yeah.
So you cannot put zero.
Zero, okay,
It's
ma'am.
still okay, but you have to put that.
Mention, yeah.
Anything new this study adds?
Ma'am, there are many studies are done for the effectiveness of the ICL lens that is manufactured by the Vision company. But this IPCL is a new lens that is manufactured by a company that is in India. So only 3 studies have been done up till now, have been published by regarding IPCL. So this is the 4th study that we have
So
done.
you said that you had a one patient with cataract.
Yes, ma'am.
So we've also like used, but we have seen that with this the incidence of anterior capsular cataract is actually higher compared to ICL.
Yeah, but ma'am, this patient was followed up till is now still in follow-up, and the last follow-up was 1 year follow-up,
Yeah.
and the cataract is still insignificant. He has no complaints. His visual acuity is stick by 12, still uncorrected.
So if something is causing cataract, you cannot really say that it is like, because you're concluding it's a safe. Safe as in it's okay, this is not, but cataract it's something which should never happen after a phakic IOL. So if you are getting cataract, then you should be cautious in concluding, because cataract is something which should not, and with this it happens after the surgery. It's not that patient develops over time. We see it very soon, like at 1 week or 2 weeks with this particular lens. So
Yes, ma'am. I saw it in the 6 months follow-up.
yeah, I understand they don't need cataract surgery immediately,
Yeah,
and it is not very visually significant, but if it's causing cataract, then we should not say it is safe. Okay. Yeah, so our last speaker is